Good morning, good afternoon, good evening all. A very warm welcome on behalf of the IAPB events team. We are very much looking forward to supporting you with today's Strengthening Capacities and Technical Acumen webinar series, with today's webinar focusing on low vision and assistive technology. I am now delighted to hand over to Dr. Nair to welcome you to the webinar today. Thank you.
Rose, thank you so much. Thank you so much for the introduction and the housekeeping. Good morning, good afternoon to all of you who have joined us, and many are joining at the moment. Dr. Yodhaji has told us that it's one of the highest registrations for this webinar. Just like to share with you that this is a series of webinars with WHO SEARO, LV Prasad Institute, especially Dr. Tara Prasad Das, and the IAPB team, which you just heard, have collaborated together to bring to all of us. It was seen that after the World Report on Vision, for SEARO, at least 4 topics needed further discussion, and the expertise available here to be brought together and to find out answers to the various problems that beseech the region. Diabetic retinopathy, integrated people-centered eye care, low vision and assistive technology, and the 4th is issues related to cornea and corneal injuries are the ones we selected for this. I would like to very much thank Dr. T.P. Das. In fact, thank him, the right English word is profusely, he and his team, for having worked tirelessly to include a large number of experts to develop the sessions which have come to you and which we'll see today also, the high class standards come to you. I would like to, in the end, thank IAPB and the team, IAPB events team, for actually taking us through rehearsals where now all of us feel very comfortable about this. And I would like to start the session so that and introduce the speakers to you, which will one by one as it comes up. It's my honor to introduce the first speaker to you. The person may not speak. We have the video recordings so that there's less glitches, or it's actually glitchless. Is Dr. Suraj Senjim, who is the additional professor of community ophthalmology at the RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences. He's the author of numerous papers on AT and low vision. Absolutely a person who's passionate about it. And the topic which has been recorded by him is going to be on current background and gaps in services in terms of facilities and training. I request my IAPB events friend to put on the video by Dr. Suraj Senjim. Thank you so much.
Hello, namaskar. Greeting from Dr. RP Center, AIMS, New Delhi. I will be talking on current background and gaps in services in terms of facilities and training. My name is Dr. Suraj Singh Sanjam, working as a faculty in Dr. RP Center, AIMS, New Delhi. In my team, I have Dr. Parijat Chandra and Dr. Shaurya Azad from RP Center, AIMS. As you know, Dr. RP Center, AIMS is a WHO collaborating centers for the last many years. And the chief of the center is the advisor to the government of India. And the faculty members of the RP Center are technical supporter to National Program for Control of Blindness and Visual Impairments. So being a WHO collaborating centers, it is our privilege to be a part of this WHO Southeast Asia region initiative to strengthen the very important field of eye care services. So I will start my talk with the magnitude of the problems in Southeast Asia, and then the current practices, and followed by the infrastructures and facilities of low vision services in Southeast Asia. And finally, I will spend some time on the needs for training and capacity building for providing low vision services in Southeast Asia. As we all know that globally, based on presenting vision equity, a total of 43 million people are blind and nearly 300 million people have moderate to severe visual impairment, whereas more than 70 million people have some form of low vision problems. And unfortunately, over 90% of these low vision problems lives in low middle income countries. Now coming to the South Asia, including India, globally, the South Asia is a home to the largest blind and moderate to severe visual impairment population in the world. So around 12 million people are blind and nearly 100 million people have some form of moderate to severe visual impairment. And in the context of low vision problems, the true magnitude of the problem in Southeast Asia is unknown, but it is a public health concern in Southeast Asia. Around 20 million people have low vision in Southeast Asia. For example, in India alone, nearly 13 million people have this problem. Again, coming to the prevalence of low vision in Nepal. So in Nepal, the prevalence is around 1%, but it increases significantly in the older age groups. Again, in Myanmar, the prevalence is approximately around 27% among 40 years and above, whereas in Bangladesh, it is around 6% in 30 years and above. Now coming to the children with low vision. So the low vision among children, again, is a huge public health concerns in this region. Globally, nearly 20 million children are visually impaired, and against 90% of them are from low middle income countries. In India, the prevalence of functional low vision among the children is 2.7 per thousand children, whereas in Nepal, it is around 1.87% per thousand children. The magnitude of the low vision problem is expected to increase in the next few decades due to the various reasons like increase in life expectancy and the growing proportion of non-communicable diseases like diabetic retinopathy, ARMD, and glaucoma. And for example, the elderly population is projected to increase from 8% to 20% in 2050 in India. So this shows that there will be a huge surge in demand for low vision service in the region. Now coming to the in terms of different causes of low vision. So retina is at the top place that leads to low vision problems, followed by the amblyopia, and other diseases like corneal disease, glaucoma is also major cause of low vision problems. Now the low vision rehabilitation service in Southeast Asia. So as you know, there is a huge gap in terms of need, demand, and supply for low vision services in the region. So only 10% of person who needs the low vision services are able to access the same. So the need for such services is very high, but the supply of the services along with the low vision devices is significantly low in Southeast Asia. At the same time, very few centers provide the low vision services that also mostly are in tertiary care center and also located in urban area. Now the coverage of low vision services, why the coverage is so low in the country, in the region. So there are various reasons for the coverage to be so low in the regions. The first is due to the lack of demand or lack of health net among the patients. And the problem is concentrated mostly in the elderly as people. Perhaps it is not considered a priority in general. Other reasons could be due to the poverty and that the service and device are very costly for rural and urban poor people. And a few people, even shy away from using the low vision devices because of stigma attached to the devices. And now in terms of practices, the services, the kind of services provided in Southeast Asia, it's mostly, it's a monodisciplinary in nature. So prescribing low vision services, prescribing low vision devices is not the end of our job as far as low vision management is concerned. The majority of the services present in the regions focus mostly on assessment of evaluation of low vision and prescribing low vision devices. So this is not an ideal for low vision management. We must look into the vision rehabilitation component, as they are equally important. Now coming to in terms of human resources and other training needs, in South Asia, there is a huge lack of manpower in terms of the trained low vision eye care workforce is concerned. So there could be various reasons for this, because one reason could be a lack of interest among eye care professionals, or the eye care professionals are already occupied with other priority eye diseases. And also, it could also be one reason that during the academic course, our eye care professionals, they are not very much exposed to the low vision services. They are not trained in this field. Hence, there is a lack of knowledge as well as interest in providing low vision service. And there are very few centers that offer low vision services. A majority of these centers belong to a private organization or NGO organizations. So the current provision of services is highly skewed when you talk in terms of available of the services. So the most of the services are in the private sector or NGO sectors. So in the government sector, it's very much lagging behind compared to private sector. So, and also the kind of services even in the private sector is mostly located in the urban areas. And in terms of the infrastructure and facility for low vision services in South Asia, again, this the most of these, the low vision services can be provided in all level of eye care services, but the kind of services exists in Southeast Asia is mostly located in tertiary level health facility, and of course to some extent in the secondary level, which is mostly in private sector or NGO sector. So there's a lack of inadequate integration of low vision services into the general healthcare services. As we know that American Academy of Ophthalmology clearly pointed out that the 30% of low vision services can be provided at primary levels. So in Southeast Asia, when we talk about low vision services, the 30% of the services can be implemented in primary levels, though the strengthening of these services is also important at the secondary as well in tertiary level. Thank you so much.
Thank you very much, Dr. Suraj, for the material you have collected. A huge number of questions could arise exactly from the presentation you have made. My next speaker is going to be Dr. Deepak Bagga. He is a PhD from School of Optometry and Vision Sciences, University of New South Wales, Sydney. Has more than 20 years experience as an optometrist at the Institute for Vision Rehabilitation, LV Prasad Eye Institute, Hyderabad. Has a lot of research interests, including measuring impact of low vision on quality of life, and 14 papers in peer-reviewed journals. And the topic that has been recorded by him for us is implementation and monitoring hospital records of the low vision rehabilitation services. It's one of the areas which brings professionalism to the subject. So I request Russell and the IPB event team to please start the video recorded by Dr. Bagga. Thank you.
Hello everyone, I'm Deepak Kumar Bagga, an optometrist, and I provide low vision rehabilitation care at the Institute for Vision Rehabilitation, LV Prasad Eye Institute, Hyderabad, India. This presentation focuses on various aspects of implementation and monitoring hospital records of low vision rehabilitation services. It also emphasizes why to implement a recording and evaluation system, what are the components of hospital records, who should maintain and evaluate, when and how to evaluate. A cyclical model for continuous quality improvement or sustainability of the program includes 4 steps: plan, do, check, and act, which is also called a PDCA cycle. Herein, the first step is to make a detailed plan to record useful information about low vision rehabilitation services. A written standard operating procedure acts like a foundation describing the scope of services, service delivery model, job roles of various team members involved in the program, their skill evaluation, and regular need-based training, source of patients referral pathway, space, equipment, infrastructure development, and maintenance registers, rehabilitation need evaluation, clients' training protocols and process of care, training and management of patients. After finalizing the standard operating procedure, it is important to train the team on these standard operating procedures, including orientation to the data collection procedures. Relevant and important data points need to be captured manually in registers or in electronic rehabilitation records. Summary of this data needs to be shared with the key people on daily, weekly, monthly, quarterly, and annual basis for review. In the process of evaluation, both the qualitative as well as the quantitative performance indicators needs to be assessed. Key team members should be involved in identification of the gaps against the benchmark, planning and implementing corrective measures to continuously improve the outcomes of the interventions. These key performing indicators can be divided into 2 categories. One, indicating the various aspects of the program evaluation from the administration perspectives. For example, geographical coverage, uptake of services, and sustainability of the program. On the other hand, second category of indicator can focus on the impact of low vision rehabilitation services from the perspectives of the beneficiaries, such as their improvement in participation in their daily life, their quality of life, and satisfaction with the program. It is important to understand the situation regarding proportion of the population with low vision or blindness that has the access to rehabilitation services for planning purposes. A tool for assessment for rehabilitation services and systems can be used to collect this information and identify the gaps. If the data is not readily available, electronic medical records of tertiary and secondary level hospitals can be analyzed to identify the proportions of patients who may need low vision rehabilitation services. After setting up these services and training the human resource, it is important to monitor the proportion of needy patients that are being referred and uptaking these services. To evaluate the uptake, a benchmark can be set up based on the infrastructure and capacity of human resource to provide low vision rehabilitation services in a day, week, or month. For example, if assessment of a person with low vision required skill training, counseling of family members, and writing reports takes 2 hours, and only 1 person is employed to provide all these services in a typical 8 hours working day, she or he can provide care to only 4 persons. But if there are 2 members with task sharing, the capacity to provide care can improve. After setting up benchmark, utilization of these services needs to be monitored periodically to understand the optimum utilization of resources employed for setting up these services. Several barriers related to uptake of low vision rehabilitation services have been reported in the literature. To improve the uptake, awareness among professionals, clients, and family members needs to be created at multiple levels. Optimum utilization of services may keep the team of service providers and funding organization motivated to sustain the services for long run. If there's a model of cost recovery from the beneficiaries, optimum utilization may ensure 100% cost recovery and financial sustainability of the project for long run. However, underutilized and funded projects would require the management to constantly seek for funding opportunities to sustain the project. In rehabilitation practice, we come across several people who may want to return their assistive devices as they don't use it or they don't want to use it. The reasons for abandonment that have been reported can be classified into 4 groups. Personal reasons such as lack of motivation, poor self-esteem. The second reason is device-related factors such as portability, ease of handling, cosmetic appearance. Third could be environmental factors, including support and attitude of people and immediate family members, people at workplace or classmates, permission to use assistive devices at workplace or in school, inadequate training in use of assistive devices. So to address all these issues, multi-pronged approach, starting with the counseling of individual, providing adequate training, guidance to family members, and sensitizing people in the patient's family, workplace, school, and in general society is needed. To understand the individual's rehabilitation needs, a structured visual function questionnaire can be used. For adults, Veteran Affairs Low Vision Visual Function Questionnaire that has 48 questions is recommended. Another comprehensive tool is Activity Inventory, having 459 questions developed by Professor Messoff. For school-age children with low vision, our team developed LV Prasad Functional Vision Questionnaire. It has 23 items. To measure the impact of vision impairment on person's quality of life, pre and post intervention impact of vision impairment questionnaire can be administered, and data evaluation can reveal the improvement in quality of life score. The indirect measures of quality of life can be obtained using time trade-off questions or through vision and quality of life index, for which the population scores have been assigned to evaluate the impact of vision impairment on person's quality of life index. These indirect measures of quality of life, that is also known as utility values, are used to derive the quality adjusted life years gained for each dollar spent on rehabilitation interventions. These assessment of QALYs, which is quality adjustment life years, across different interventions, across different health conditions and programs, allows comparison of most cost-effective interventions and programs for the funding organizations to prioritize their fund allocation. Many funding organizations consider the satisfaction of beneficiaries with the services provided and use of assistive devices that were provided through the project or insurance. A standardized patient satisfaction survey or cubic user evaluation satisfaction with assistive technology can be used to measure the user's perspectives. Given the multiple program-related key performance indicators and effectiveness measuring tools, the service providers may need to select a few to make the process of implementation monitoring a practical exercise. Priorities set by the team lead management for organization, keeping in mind the requirements of the government or funding organization, scope and objectives of the program, and available resources may guide or influence which of the 2 or 3 factors to be captured for periodical monitoring. Implementation and monitoring of hospital records of low vision rehabilitation services is a continuous and cyclical process. It is important to clearly assign people the responsibility to record, report, and review the key performance indicators. Reviews may suggest revisions in program, protocols, and procedures to continuously improve the effectiveness, coverage, and sustainability of the program. Thank you so much for patient listening. I'll be happy to answer the queries if any. You can send me your questions to my email address. Thank you.
Dr. Bagga, thank you so much for bringing up issues and asking for the questions. I'm very pleased to inform all my panelists and the participants here. There have been a number of questions. I'll rapidly touch upon them. Saman Senanake from Sri Lanka has asked that we have services in Sri Lanka but don't have devices. So that's a question which actually some of us are going to deal later on, but I'd like to inform my panel that this is a question, as that's not a priority for the government. Dr. S. Alan from Vishakhapatnam, Teja from Vishakhapatnam asks, even after counseling people, they don't purchase the devices. Why? I think that answer may be known to many of us, but that raises a question that devices have to be brought to people, and if they can't purchase, how do we get them the devices within the CAD? So Daniel has asked a question, is an excellent question, and a thought-provoking one, like others, but it's a dimension further. Is how about integration between ophthalmology and optometry facilities and schools for the blind to answer some of the issues? And I request my panelists and the experts to go to the Q&A function and start responding to some of these questions as I feel, because we may not be able to deal with all the questions in audio one. The third one now is my great honor to introduce Ms. Sarika Gopalakrishnan, who is a senior optometrist and HOD of low vision care services at Sankar Nethralaya, Chennai. She has 12 years of experience. And the interesting fact is that she's the first Indian female who is a fellow of the American Academy of Optometry in the low vision. Not a mean deal, Dr. Sarika. And I call it doctor because I know you are appearing for your PhD. So it's fine enough. And there have been a number of papers. So she's going to, her video rather, is going to speak to us on how to strengthen clinical services in low vision rehabilitation.
Hello everyone. The title of my presentation is How to Strengthen Clinical Services in Low Vision Rehabilitation. I am Sarika Gopalakrishnan, optometrist HOD of Low Vision Care Services in Sankar Nethralaya Eye Hospital in Chennai, Tamil Nadu, India. I would like to thank World Health Organization and my institute, Sankar Nethralaya, for giving me this prestigious opportunity. In this presentation, I will be covering infrastructure, clinical evaluation, low vision devices, optical devices, non-optical devices, electronic and latest assistive technologies, and rehabilitation services. According to World Health Organization, a person with low vision is one who has impairment of visual functioning even after treatment and or standard refractive correction and has a visual acuity of 6/18 to light perception or a visual field of less than 10 degrees from the point of fixation, but who uses or is potentially able to use vision for the planning and or execution of a task. So it is clear that low vision is not equivalent to blind. Let us try to understand this further. Say suppose, even after the best possible treatment, the patient asks, "Doctor, will my vision improve further?" The doctor responds to the patient by saying, "Don't worry, please consult the specialist at the low vision care clinic." When a patient comes to know that there is no treatment for their ocular problem or their visual acuity will not improve further, they experience anxiety, fear, depression, denial, etc., and pass through many psychological stages. Low vision care services help and prepare these patients to accept their ocular condition and move forward in their life with confidence. Infrastructure. To create an optimal setup to provide low vision services, adequate space, appropriate lighting, essential equipment, and trained manpower is critical. The infrastructure needs to be differently abled friendly. We need to have contrast enhancements, and the patient should be able to replicate similar environmental modifications at their home. For example, tactile clues on the walls can help them navigate independently. Similarly, they can use directions on the floor that can lead them to the pathway. Clinical assessment. Successful management of the problem can happen only when there is effective evaluation. So, evaluation is an important part of any low vision workup. Clinical evaluation. The clinical evaluation includes history taking, identifying visual acuity, task specific need, functional vision assessment, refraction, contrast acuity assessment, color vision, Amsler, and confrontation. There needs to be a standardized format like a proforma for history taking. This is a sample worksheet that we use in our clinic. The questions need to be asked in an organized way that it has to be open-ended questions. To understand the visual demand in each domain, the eye care professional need to develop a rapport with the patients. This will help them define the primary need. To identify the visual demand, the eye care professional should ask questions in such a way that the patients are encouraged to explain visual difficulties faced by them in their day-to-day activities. For example, for distance, the patient may face difficulty in seeing a signboard or a blackboard or a bus number. For near, they may face problems in reading, writing, or spotting tasks. While using a computer, the patient might have difficulty in typing on a keyboard or seeing the screen, or glare could be a problem. With mobiles, using the keypad, seeing text messages or contacts could be a problem. With mobility, navigating indoors or outdoors in both familiar and unfamiliar environment could be a challenge. Photosensitivity could also be a challenge, and the patient might face difficulty during daytime or nighttime or both. The patient should be asked relevant questions on these points, and these responses should be well documented. The patient might have difficulty in their day-to-day activities. It can be about eating, seeing food on table, cooking, self-grooming, organizing things in a place, identifying objects in a group, color perception, currency identification, personal hygiene, etc. When we understand what all difficulties the patient is facing, we can plan the management accordingly. Let's now move to the assessment part. We can use a standard logmark chart to measure visual acuity. To evaluate the visual acuity and the contrast acuity, we can use the Bailey-Lowy high-low contrast chart. Berkeley Rudimentary Vision Kit (BRVT) can be used for quantifying the visual acuity of patients with ultra-low vision from counting fingers to perception of light. These are the charts used for quantifying the near visual acuity. Depending on the visual need of the patient, the chart should be selected. If the patient wants to read a continuous text like a newspaper or a book, then M1 read continuous chart can be used for assessment. If the patient is interested only in spotting tasks and does not have any reading habit, then number chart or assorted word chart can be used. If the patient is a pre-verbal kid, the symbol chart can be used. After performing the visual acuity assessment, a detailed objective and subjective refraction need to be done. Contrast acuity measurement can be done with a logmark chart. D15 test helps in color discrimination and used for assessing the color vision. The test should be performed binocularly with appropriate illumination to test the functional color vision of the patient. The Amsler chart is used for assessing the size and position of the central scotoma. If the patient has a tunnel field of vision, then the peripheral construction of the field of vision will be picked in Amsler, and also for patients with metamorphopsia. Low vision devices. These are the optical devices used for distance viewing. The monocular telescope, binocular telescope, spectacle mounted telescope, autofocus telescope, and spectacle model binocular telescopes are prescribed depending on the visual demand. For example, if a patient is a school student and wants to see the blackboard or a signboard, the monocular handheld telescope will be given. If the patient is elderly and wants to watch TV or has difficulty in recognizing faces, the spectacle model binocular telescope will be prescribed. These are the optical devices for near work. Most commonly, students prefer to use spectacle magnifier and dome magnifier. A stand magnifier can be used for continuous reading. A handheld magnifier or pocket magnifier can be used for seeing bills or challans. These are the non-optical devices. A signature guide is used for signing tasks. A notex helps with currency identification. It can be customized according to the currency of that particular country by measuring the length, width, and height of the currency note. Letter writer helps the patient to write along a straight line, and reading stand helps to maintain a better posture. These are the devices that can help patients with photophobia. They are clip-on filters, tinted lenses, multiple pinhole glasses, wide-rimmed hats, umbrella, and sunglasses. These are the electronic low vision devices. Video magnifiers magnify the content and help the patient in reading the printed material. There is a wide range of video magnifiers that can magnify up to 100 times. This will also help in reversing the contrast of the letters and background. There are lots of other options for viewing both the distance and the near objects comfortably. There are desktop models, mouse models, and handheld portable video magnifiers, which will be useful for the patient to read independently. There are devices with auditory output also. Classmate Reader helps in reading e-books downloaded from the website. RNIB Penfriend helps in recording the voice input on a magnetic label. It can be stuck on any surface or medicine for later use. Intel Reader helps in scanning and capturing any printed material or a book, and it gives both audio and video output. These are the latest assistive technologies that can help a person with low vision to be independent. eSight helps in viewing distant objects. With the help of OCR technology of ORCAM, blind patients can read any printed material. Oculus Rift virtual reality technology helps in creating a virtual environment for assessment, training, and rehabilitation. Samsung Gear augmented reality device helps in improving the visual acuity for distance, intermediate, and near. For those having difficulty in using the computer, there are a lot of inbuilt modification and screen magnification software like Magic, Big Shot, Zoom Text, etc. With this, they can work independently on a computer. For patients having a minimal vision or blind, screen reader softwares like JAWS, etc. are available. Similarly, there are mobile software and inbuilt apps. Some of them are listed in this slide. There are assistive devices that help patients with their day-to-day activities right from the time they wake up till they go to bed at night. Some examples are a talking alarm, tactile clues, braille tags, measuring spoons, liquid level indicators, etc. With the help of these devices, the patient can lead an independent life. Rehabilitation services. We teach those having difficulty with mobility and those having tunnel field of vision head scanning techniques, sighted guide technique, and provide them mobility training with a cane or a smart cane. For children with special needs and multiple disabilities, functional vision assessment is mandatory. Based on their needs, we need to prescribe them with glasses and low vision devices. Participation of parents in this process is very important, and they should be motivated and encouraged to help their children achieve their full potential. It will help these children live a better quality of life. There are other visual rehabilitation services like early intervention, remedial education, perceptual training, eye-hand coordination, schooling guidance, home management, mobility training, and vocational training. The low vision patient will be eligible for getting concession and benefits by getting a disability certificate from the government. The patient will be eligible to get pension, scribe, or a reader allowance, loan for education and business, job reservation quota, income tax relaxation, travel concession for roadways, railways, and airways. The concession and benefits will vary depending on the country they live. The low vision care services need to have a multidisciplinary approach. With a comprehensive low vision training, optical and non-optical devices training, assistive devices training, independent living skills training, counseling and referral services, early intervention, schooling guidance, braille training, digital resources, computer training, mobile technology, and employment assistance. So, with appropriate low vision services, we can help our patients with low vision and blindness live a confident, independent, and happy life. Thank you.
Thank you so much. And Sarika, it's a pleasure. And I would want to take just half a minute to remind my participants here for some of the points made by the three speakers. I could have done it after 4. I'll again do it after all of them. Dr. Suraj gave us data and brought us that only 10% or even less persons who are in need of low vision assisted devices, they get them. And in Southeast Asia, it would be much less. Dr. Deepak brought out a startling fact that around 3% to 50% devices are abandoned, and the mean is 25%. So we have questions from our participants saying they're not getting devices, but Deepak ji points out that those who get, they abandon them. So as it's so. So that's going to be a brain tickler to all of us, that you get them devices, but people abandon. And Dr. Sarika brought up 2 or 3 very good points, how to make the assessment easier, the devices to be made available. We have questions, and I find Dr. Saman, our friend from Sri Lanka, is actually quite frustrated that he has tried out many ways, but still not getting devices. And then she talked about the multidisciplinary approach. We will need them. Before I go to my last presentation, my request to all our experts and panelists is that there are very good questions waiting in Q&A. Please provide your inputs and answers to them. I know the questions disappear once you answer, but you could see the question and answer it, as a question for yourself also, whatever. So please start responding to them. We will not have time to answer all those questions, alive. Although Dr. Sarika wants to answer one of the questions live. My now present duty is to invite my friend and Dr. Beulah. In fact, she's the one who has assisted me in developing the presentation on AT, which I use globally. And I never fail to thank her, because how much of time she spent to assist me with that. Beulah is a PhD in Vision Sciences from the University of New South Wales, Sydney. She heads the Institute for Vision Rehabilitation at LV Prasad and has 29 years of rich experience in rehabilitating people with visual impairment. 29 years. Her clinical interests are in functional vision, early intervention for children with vision issues, and multiple disciplinary and assistive technology. As I informed all of you that she was the one who put me, who enriched me with when I was starting all this area. And her recording, which is actually been made by one of her colleagues, as when you see the recording, is on evidence-based vision rehabilitation services, referral mechanisms, and policies in WHO-SEA. So that's where it comes in now, the official part and the referral examiners. So over to the presentation, Russell.
Hello everyone, I'm Rebecca Sumalni, optometrist practicing low vision at LV Prasad Institute, Hyderabad, in India. This presentation is an effort by our team consisting of Dr. Beulah Christie, the head of Institute for Vision Rehabilitation, and Dr. Deva Jayaraman, the senior rehabilitation specialist from Institute for Vision Rehabilitation at LV Prasad Institute. Established in 1987, LV Prasad Institute is a comprehensive eye health care facility and a World Health Organization collaborating center for prevention of blindness. Vision rehabilitation is one of the active arms of our institute. In this presentation, I will be discussing models of care, the referral mechanism, and policy recommendations from evidence-based best practices in WHO's Southeast Asia regions. Vision rehabilitation services have a key role to play in mitigating the consequences of vision loss and enabling people with visual impairment to meet their full potential. The primary role is to help people maximize functional independence, maintain the quality of life, and cope with the psychological aspects of vision loss. The key objectives of vision rehabilitation are to prevent the loss of function, to slow down the rate of loss of function, to improve or restore the function, to compensate for loss of function, and for the maintenance of current function. Vision rehabilitation services are delivered through different approaches. The most frequently practiced approaches from the literature are the center-based method and the community-based rehabilitation method. The mixture of both approaches is rarely practiced. The center-based approach is predominantly clinically oriented, and usually low vision care is delivered at the eye clinics and hospitals. Ophthalmologists and optometrists are usually the service providers. The primary focus of this service model is on the prescription of low vision devices with minimal cross-disciplinary consultation for rehabilitative care, whereas the community-based rehabilitation approach is targeted to an individual's specific home environment with efforts focusing on environmental adaptations to support the independence. The strength of the community-based approach is that they can be made available in rural areas with limited infrastructure and community resources, including people with disabilities themselves, their families, and communities. The combined approach of service delivery is beneficial for more holistic rehabilitation, especially for children with vision loss and multiple disabilities. The WHO suggests the delivery of low vision care at primary, secondary, and tertiary levels. It is recommended to meet the needs of the low vision population, about 30% at the primary level and 50% at the secondary level. It's only the remaining 20% of patients with low vision will actually require the services by the tertiary level care. At the primary level, community-based workers provide vision rehabilitation and refer people with low vision to a higher level of service. At the tertiary level, a team of trained professionals offer advanced care in a specially developed low vision clinic or hospital. The critical interface between these two levels is a secondary level of care, which provides district level low vision care. It's important to consider the population density, the geographical coverage, and accessibility while planning for low vision care. A comprehensive approach is needed to work in rehabilitation, including human rights, inclusive education, independent living, advocacy, assistive devices, etc. However, one-fits-all approaches for service delivery cannot be applied for WHO Southeast Asia member states, as it can be influenced by country-specified determinants. At the same time, there must be a minimum standard of care uniformly followed by all WHO member states at each level of care along the lines of universal access to health. The WHO's guidelines on the international standard for low vision rehabilitation is towards this purpose that guides all aspects of the establishment of vision rehabilitation and rehabilitation services at all levels of healthcare from primary to advanced services. These standards provide guidance about essential services to be provided, the equipment needed, and workforce that is required for different levels of care, beginning with primary level to advanced tertiary level. Rehabilitation is a set of measures that assist individuals who experience or are likely to experience disability to achieve and maintain optimal functioning in interaction with their environments. The rehabilitation process involves the identification of a person's problems and needs, relating the problems to relevant factors of the person and the environment, defining the rehabilitative goals, planning and implementing measures, and assessing the effects. The L.V. Prasad Eye Institute's pyramidal model of eye health demonstrates the integration of low vision rehabilitation services across its network. This model emphasizes the creation of sustainable, permanent facilities within communities, staffed and managed by locally trained human resources and linked effectively with successively higher levels of care. Beginning at the bottom of the pyramid, delivering services through the trained community workers, the service needs are facilitated at different levels, ending at the center of excellence at the top. Through this integrated model of care, L.V. Prasad Eye Institute is providing comprehensive rehabilitative care to individuals' needs based at all levels. The Global Burden of Disease Study estimates the prevalence of developmental disabilities in children under 5 years to be 52.9 million. Alarmingly, the current prevalence is similar to than it was in 1990 with 53 million, suggesting inadequate global attention on the developmental potential of children. Vision loss was the most prevalent disability, followed by hearing loss, intellectual disability, and autism spectrum disorder. About 95% of these children lived in low and middle income countries, particularly in the sub-Saharan Africa and South Asia, inviting an immediate call for action by the WHO state member organizations. Their unique needs demand a more complex approach to intervention from multidisciplinary resources. The early intervention model in LV Prasada Institute, that's located in South India, provides evidence for impactful intervention. The intervention provided at this center is unique to a child's requirement and family-centered. It includes assessment for developmental milestones, in addition to traditional methods for ocular diseases and visual acuity, specialized therapy in cognitive, motor, and other sensory areas, parental training, and advocacy. The well-defined protocol in the care of children with special needs developed by the center is a ready reckoner for other member states to implement these unique services. In all 11 member states of WHO Southeast Asia, the early childhood programs are an implementation under early childhood care, education, and development initiatives supported by various government, non-government, and other international agencies. These programs support the growth, development, and learning of all children from birth to 8 years of age, with a key focus on health and hygiene, nutrition, developmental activities, and parental guidance as per the National Early Learning Developmental Standards prescribed by the respective ministries and United Nations organizations. Integration of care and education components is a recent but increasing phenomenon in many countries like Bangladesh, Nepal, and Sri Lanka, while some countries such as the Pacific Island states, Bhutan, Maldives still tend to focus on preschool education. In addition to the general childhood care, country-specified programs for children with developmental delay and disabilities are existent in the few WHO Southeast Asia member states like India, Sri Lanka, and Thailand. The Indian framework published by UNICEF in 2020 on early childhood and early intervention programs is a successful model to replicate by other member states. The framework provides an overview of different fundamental elements to be looked upon in the execution of childhood programs that represent the policy frameworks, the flagship programs, the service delivery platforms through which the frontline workers and functionaries reach to the children, parents, and other caregivers throughout the country. Lack of access to low vision rehabilitation services can increase the effects and consequences of diseases, limit activities, restrict participation, and decrease the quality of life. Despite the importance of vision rehabilitation for its benefits to improve the psychological well-being, the services are accessible to approximately 15% of people around the world who could benefit. Early referral to vision rehabilitation services is the key to improve the underutilization of services. Referral to low vision rehabilitation service is often decided on visual acuity threshold and visual field loss criteria. However, the criteria for referral based on these two visual functions alone is not sufficient, as other factors listed here equally impact the visual functioning and quality of life. An effective referral system should connect services between all levels of the health systems and should ensure to provide the best possible care closest to people who approach for services. A good referral system can help prevent a high proportion of clients seen at secondary facilities who probably could have been appropriately looked after at the primary level itself. Strengthening the referral mechanism can help clients receive optimal and timely care at the appropriate level and can help the facilities for optimal utilization of their capacity cost effectively. The key process of a referral mechanism involves components as shown in the flowchart, such as the health system, the service seeker or referral initiating facility, the service provider or the receiving facility, and the supervision and capacity building. These can be adjusted as relevant to the local situation, such as capabilities of lower levels, availability of specialized personnel, cultural issues, population and density, and the distance between the centers. For a referral system to work at its best, all levels of health system needs to be functioning appropriately. This includes each facility being clear about their role, responsibilities, and limitations. The health system should plan everything essential to facilitate the referral. The planning should cover aspects such as potential service providers in both private and public sectors, suitable means of communication, availability of transport, capacity building to strengthen human resources, and a clear protocol for the referral. The referral protocol, formalized and mutually agreed upon between the service providers, should be readily available for use. Strengthening primary level services should be given priority as this can prevent a large number of people with low vision and blind visiting higher level centers which can be provided at the primary level itself. Ophthalmologists and optometrists play a very important role in identifying the referral need of their patients for low vision and rehabilitative care based on the referral parameters that we discussed earlier. The decision to refer might be distressing for the client and the family. So when deciding to refer, it's important to give the client and the family members the relevant information such as reasons for the referral, where to go, who will attend to them, what is expected, etc. In some situations, it may be required to communicate with the receiving facility to make an appointment or other arrangements for the referral. Whenever a referral is initiated, sending a written record of the clinical findings, any intervention that has been given before referral, and specific reasons for making the referral is highly helpful. There should be a referral register at each hospital and service facility, which is interlinked with state and nationwide central resource to ensure the tracking of information of clients referred and those who have received the low vision and rehabilitative care. A sample referral form and central register are shown here, where possible digitalization and automation to referral mechanism is highly recommended. If forewarned, the receiving facility can anticipate the arrival and receiving the client with their referral form. They will use the information sent on the referral form to begin a thorough assessment of the client and begin management of the case. The receiving facility will use its particular resources to provide the clients with high quality care and maintain documentation according to agreed standards. As the client progresses, the receiving facility will plan the rehabilitation or follow program with the client and their family or support network. The responsibilities of the receiving facility begin with reviewing the referral form and understand the clinical information and personal recommendations made by the clinicians. On this background, further management should be planned in consultation with the clients and their family members. The comprehensive plan of management should be individual need-based in consideration of factors relating to activity limitations and participation restrictions. Sending feedback to the initiating facility on the appropriateness of the referral and intervention provided will help in ensuring an end-to-end documentation of referral processes. Like the initiating facility, there should be a referral register at each hospital and service facility, which is interlinked with state and nationwide central resource center to ensure tracking of information of clients referred and those who receive the low vision and rehabilitative care. There should be a system to periodically monitor all referrals made to and from facilities. This will help in understanding the effectiveness of the referral mechanism and to take further action to strengthen a particular part of the referral system or its procedures. The United Nations Convention on the Rights of Persons with Disabilities was ratified by 10 SEARO countries, except Timor-Leste. All the 11 SEARO countries have implemented the Vision 2020 program. Nation-specific acts and strategic planning for persons with disabilities have been implemented in all the nations. For example, the Rights of Persons with Disability Act of India. Various activities such as regular eye health programs have been implemented to screen for those with avoidable causes of visual impairment and also rehabilitate those with irreversible conditions. Region-specific guidelines have been developed based on the prevalence of the condition and keeping the healthcare system in the loop. For example, the screening of all premature babies in India to rule out retinopathy of prematurity. As it's known, similar to persons with other disabilities, even those with visual impairment are eligible to avail social security benefits based on their extent of vision disability. The important areas such as educational concessions, for example, a video scribe facility, employment opportunities such as separate quota for government jobs, travel concessions, disability pensions, and provision of assistive devices are all included as part of these benefits. Various epidemiological studies, situation analysis, and various rapid assessment of avoidable blindness surveys are being used for advocacy and planning in all the nations. However, there certainly exists a significant scope to improve vision rehabilitation in various aspects. Although comprehensive acts are in place for those with visual impairment, all the nations are yet to fully implement the same in both urban and rural settings. This ongoing pandemic has posed different challenges to the healthcare sector, and vision rehabilitation has not been spared either. The immediate need of the hour is to have specific guidelines that can be followed for providing vision rehabilitation during the pandemic phase, such as this. One field that has seen the light of the day in this aspect is the television rehabilitation, which needs significant improvement in both service provision and uptake in all nations. As always, the key to strengthening any facility is to nourish the grassroots level service. On similar lines, as the majority of the population reaches the primary eye care service due to its proximity, the primary eye care practitioners need to be sensitized and trained in delivering primary vision rehabilitation services. The referral system, as discussed earlier, should also be well coordinated for the person with visual impairment to receive the needed care as discussed earlier. Thank you, and we're glad to take any questions or comments.
Thank you so much, Dr. Beulah, Dr. Rebecca, for this presentation. 3 or 4 points which come out so that then we can go to the question and answers and with the panel is center-based approach and the community-based approach. They both have their own strong points and both are complementary. This is not either or, it is and. Vision rehabilitation could be carried around to 30% at the primary level itself. What an eye-opener. And you hardly find any country or any part of the region here which can come anywhere near to this figure, and the 50% at the secondary level. No wonder people rush only to the tertiary centers, which is and making the reverse pyramid. What Beulah is suggesting, the reality is entirely reverse of that, and that's what we need to change. And that's what I want my panel of experts to remember, that when you answer what we're talking about, I won't even call it ideal situation, maybe what needs to be done, and what at the present is there's a huge gap, chasm, yawning gap waiting. She also talked about early childhood prognosis as a area, evidence-based practices, and the last slide was talking about lacunae, the gaps, the challenges remaining. I'm going to introduce my panel, but before I do that, and Russell has written to me that he will spotlight each one of them there. There'll be certain additional questions which have come up. Fairlin Soji has asked that we need to quote not only WHO, but also the CRPD Act also, very right. We also have Sumit Grover telling us the importance of orientation and mobility training along with the LVA very much, and I'm sure Suraj Sanjam will answer you on that, where that is being done. Daniel has again asked whether iCamp model can be used for LVA or has been used. Interesting viewpoint, interesting point. And I see no reason why not. That is personally my answer, but I would like to provoke answers and thinking on this from the panelist of experts. Dr. Padmaja has asked, in fact, was the first one to ask, how do we impact the need, demand, supply triad? It's not a demand and supply triad. She makes it very obvious that there's a need also, which is hidden, and we talks about it, need, demand, supply triad with regarding to both, that is products and the services. So by orienting these points, and I like to take up, introduce my panel of experts after the experts who have spoken. I have first Dr. Sara Varghese. Maybe you can spotlight her, Russell. She's the country director and managing trustee of CBM India, pioneer work and rich experience in the rehab area. And you will be all happy to know that she is at the WHO SEARO. She has provided and understands the WHO system as an enriched it when she was at WHO SEARO. before I came back from Manila and Maldives in this position here. Second, we have Dr. Nahid Firdausi Snigdha from Bangladesh. She is the Associate Professor, Department of Low Vision in the National Institute of Ophthalmology in Hospital, Dhaka, Bangladesh. She is highly active at the community level to raise awareness and advocacy for the low vision, and does many other functions. We have Dr. Asila Abedira from Sri Lanka, who is the President, Association of Community Ophthalmologists of Sri Lanka. He is the former coordinator for Vision 2020 Sri Lanka and former country chair for IAPB in Sri Lanka. That's what he has been, there, and is one of the panelists. We have the fourth panelist from Bhutan, and you can identify him by his distinctive Bhutanese dress, a lovely dress. Indra P. Sharma, and clinical optometrist, from there, and from GKC Wangchuk National Eye Center, JW2 National Referral Hospital, Thimphu, Bhutan. And along with him, I'm very pleased to inform you that we have senior people from the government, Madam Kinley, and many others from Bhutan who have joined in. I also want to point out that many of the postgraduates and optometrists have joined in. I have been having personal communications. You cannot see all their legends when you see the participant, you can only see their names. So it's a very enriched group, and we can hear from them. So I'm going to open up the panel discussions to all 8 of the experts here. And as I try to wet on them with some of the questions and some of the provocations which the 4 presentations have brought to us. But my first question is to Dr. Sara. I try to take the questions to Dr. Sara. Is this one of the important barriers to access is poor availability? And as you see, someone has been also talking about in others also in the question area. So how can the availability of the low vision aids be increased? And is there a role for non-medicalization of the LV working with education / social services / etc. for this? So that's the thing. For the increasing availability, do you see non-medicalization would be a useful answer to go, the path to take for all of us? Over to you, Dr. Sara. Please, with the next 100 to 120 seconds, do that so that we can come back again for another question.
Thank you, Dr. Nayat, and thank you, IAPB, as well, for allowing me to participate in this very important webinar. I'll start with the question of non-medicalization. So we've already heard from the panelists that it's somewhere around 10% of people who need low vision aids who actually get them. It depends on the country. And if we want to reach out to all these people, if we stick with those who reach eye care services, we're going to stay around that number. Low vision who are out in the community, of course, they don't know they have low vision, but the people they are interacting with are the organizations of people with disabilities, the social sector, or the social services wings of their government, not the health sector, and also the education departments. And there needs to be an effort to make these sectors aware about low vision so that they suitably direct people to the services which are available. And of course, we have to work on making more services available. The second aspect I would like to bring in is because, especially regarding the question of availability of low vision aids. When CBM started its work in India on low vision, almost every low vision aid was imported into India. Now, there are a large number of manufacturers manufacturing high quality low vision aids. And from the point of view of a manufacturer, it is a demand which is important. If you create the demand, you can be sure that the manufacturers will make the supply. So, we need to increase the demand, and the business people, they are there to manufacture it for us. As it has increased in India, I'm sure it will increase in every country in Southeast Asia. And, our manufacturers are also very innovative. They're happy to export as well. So this is
Thank
a
you.
very brief answer.
Yeah. No, I see. Yes, we are brief, but I think you really brought up, and I think it also relates to Padmaja's question. She asked about the need demand. You're very nicely linked up. If there's demand, there will also be supply, and we need to create a need first and then a demand. Thank you so much. I'd like to open up to any of my other participants, panelists, that they want to add on to Dr. Sarah for the next 30 seconds or so. Anybody wants to add on? Otherwise, I'll go for my next question to Indra. Would anybody like to say, Beulah, something for the 30 seconds, or Suraj, to add on to Dr. Sarah's work? Because there's a very important question, how to make availability. Or maybe you can think and come up later. Yeah, Beulah. Yes, Beulah.
Yeah, I totally agree with Dr. Sarah's point. So initially, when we initiated the low vision services, it was the same thing that we had in mind. Like it was the same concern we used to raise all the time. As rightly pointed, like at once when we raise the demand, there are more vendors. They are coming forward as to supply the devices.
Yeah, but I'd like to add on here that other issues like of standards, the manufacturer, the cost, the prices, and where does it come from? Till now people have been debating about philanthropy. As our Sri Lankan friend has been pointing out, the governments are not interested. So why they are not interested? So I think one of the points I'd like to provoke the panel and the participants is, how do we bring governments onto this? And by government, I mean the broader way, not only Ministry of Health, many others, institutions, other ones, academics there. So let's think on it, this further point, and maybe some of you like to come back in other questions. My next question goes to Indra. Indra, why are the LV services not easily accessible? We talked about availability, but other question comes up. Beulah, your hand is up. Would you like to say something more, or that was the previous one?
In India, we have many schemes through government. We are able to get the the devices, low vision devices. One such scheme is ADIP scheme. So I'm sure like the more we pressurize the government, the government will be willing to consider and take this as the priority.
Thank you so much. Excellent answer, and we need to share it with other countries also. So maybe the answer to you, the question to you, Beulah, is later on to talk to Saman and others, is to say how some pieces in India, jigsaw pieces, have been put together to bring government on the bandwagon. So how other countries can do it. So that's the way we all have to work together. The work doesn't stop with the webinar closing today. The work actually starts to support each and every country, because people who need LV services everywhere are suffering, and we need to do something about that. So coming back to Indra, why are the LV services not easily accessible to patients in most of the countries of our region, Indra, not only in Bhutan? And what are the major challenges to providing LV services in Bhutan? Just if there is any extra challenge other than the region. So over to you for the next 120 seconds, Indra.
Thank you very much, Dr. Nair. Thank you, IAPV. Yes, access is one of the major challenges. We know 1 in 10 people are having access to low vision aids. And I feel in the region, one of the reasons why people are not having access is because they lack advocacy on the availability where you can find those devices. The other thing is the affordability of the devices, because most of the time it's not given for free and purchased. The other thing is like, though people are aware, they have to travel to avail the services, because those are not readily available in the primary health centers. Now, if we come to talk about the major challenges in Bhutan, most of the challenges are similar to what we face in the region. But in our setting, one of the major challenges is the human resource. We have just a few handful number of people are trained for low vision devices, maybe 3 or 4 in the country. So it's a huge challenge for us. Other thing is lack of evidences. So we at present we don't have any evidence on the disability prevalence, or maybe the barriers to this disability. We don't have any evidences. So we are trying to generate evidence on having access to assistive technologies. And
excellent.
Yeah, thank you.
Okay, thank you so much, Indra. And then you really raise a point. And in fact, because I've been working with you and Kinleji and others from Rata areas, we know the interest the group has in Bhutan, like other countries, in fact, most of the countries. But we appreciate the work done and exactly agree with your points. My third question goes to Dr. Sarika. Sarika, what roles can be played by the private providers or the NGOs, Sarika ji? And not only for the service points of view, but also assistive devices. Over to you, Sarika, for the next 100 seconds or so. We may require 5 minutes extra or so, just letting Russell and team know beforehand, but there are many questions. So over to you, Sarika.
Yeah, thank you, sir, Dr. Nair, sir, and thank you, IAPP. Yeah, that's a wonderful question. Actually, like we speak lots about multidisciplinary approach, and when we speak about the devices, especially the NGO or the government bodies can create awareness as an initial one. So as Dr. Sarah Madam said, the supply and demand has to be matched. So there are lots of demand, but many times if you practically see the patients with low vision sit at home, they without knowing the availability of these services. So we should make them understand that this exists first. Then only they will come to the hospital or even to the primary care center. They don't know that these kind of devices exist to improve their vision further. So especially in villages and remote areas in any country. So we should make them be aware of that these exist to improve their quality of life and vision. And especially when it comes to NGO in terms of production and manufacturing, when we prepare low-cost devices, definitely people will be able to get it. So many times there is a very big mismatch between the need and the demand. So when there are devices available, I think it is possible through tele-rehabilitation and through other services to get it to the area where people need these kind of services. So
thank you so much. Yeah, I think I've really found, and actually that takes me to the next question, Sarika. You talked about raising awareness, that people are not even aware. So again, coming back to Padmaja's questions of need, demand, and supply triad, we can't have supply unless we have demand, and we can't have demand unless we have need, and we can't have need unless we have awareness. So that links me directly to the question I'm going to ask Dr. Nahid. There is on awareness. Dr. Nahid, see how nicely it is flowing into it, and I'm happy I sort of wrote the questions in this order. A poor awareness regarding AT products and LVA in particular is one of the reasons, as Sarika has pointed out. What are your suggestions to overcome this? Over to you, Dr. Nahid. You've been working in this area.
Thank you, sir. I think poor awareness is the most important issue in low vision services. Despite significant number of persons in need of low vision services, these services have not been given due importance in many of the countries of the Southeast Asia region. When low vision is not a priority issue, service providers have a tendency to give up, saying and thinking that they have reached the end of the road in eye care. But the fact is not that. Actually, this patient must be handled with empathy. This patient should be rehabilitated through both vision rehabilitation and social rehabilitation. But lack of information about low vision among patients, their family members, even healthcare providers and other stakeholders make a big challenge for low vision services. So there are some way to overcome this process. So we can follow some steps to raise the awareness. And I think that as WHO come forward to strengthen the low vision services, this itself acts as an initiative of raising awareness.
Thank you so much. Yeah, thank you so much. You want to add something? Okay, another 10 seconds.
Yes,
go ahead.
Sir, I just add 2 to 3 points. That is, I think that policymakers should be involved in the process by organizing the roundtable or sensitization meeting among the different stakeholders, and also involve local administration and local government as they have opportunity to support patients as they have budget, local budget.
Excellent point, Dr. Nahid.
IC material also, that is in poster, leaflet, X-banner, festoon, so that these materials can be used in patient and family education program, and also raising the public awareness. Arrange media campaigning, both electronic, print, and social media.
Thank you so much. You really brought up many points, but it's again linked to what Indra and others have said about is, the human. Who's going to make the pamphlets? Who's going to make the brochures? You don't have technical people who also have communication strategies and communication clarity. to do that. So that's where, when we talk about the ways to go about, our job is also to identify the gaps related to each. It's like the fishbone analysis. You want communication strategy, communication material, who's going to prepare for that? So unless we do it locally, and I think very good point you brought about the local governments, the municipalities, that's where the answer lies, and that's where the Nordic countries and others are done. The question number 6 go to Beulah. Beulah, this is again on awareness. Two of our previous speakers have really brought about the awareness raising even the users, not only for the policymakers. So the question is, one way to improve awareness and provide the needed services to have models. Do you have, could you suggest some models which we can talk about? One model, more than one model? You're silent. You're mute. Beulah ji, unmute yourself.
Yes, Dr. Nair. Yes, certainly. The models that we have, discussed, like LV-based model and the one which Sarika presented, and then the Arvind's model, and then the AIMS model, and then a couple of many other models that I have studied for the presentation in other regions, like especially in Sri Lanka. There are many models that is available. But one key is trying to replicate what LVP is doing or Arvind is doing is not good. We need to analyze, what is good for us, at what level you want to start. Do you want to start at the primary level or the secondary level or the tertiary level? So decide on that first, and then based on that, you establish everything else, your human resources, your equipment, and then at that level, whom do you want to empower them or educate them? So all of that, based on that you have to do. Yes, there are certainly many models existing, but one need to be very careful in choosing what is applicable to that particular region.
Okay, thank you so much. My one request to you, Beulah, would be, and if you could, you and colleagues at LVAPI could coordinate to have half a page or a one pager each on the various models you mentioned about, and we can share, through the email we can send to IAPB, and they can send to all the people who join. It'll be useful. I think modeling is a very important, and I think you made a very good point saying that we don't have to replicate only that models, but they could become a stepping stone, for some countries or even a localized area to adapt from it rather than adopt it totally. So excellent point. My question goes to Dr. Senjam. I know you have a point on this also. You please join both the points. Dr. Suraj, you made an excellent presentation. In fact, all the 4 presentations merge beautifully into and raise the points. So what are the requirements to have skilled and sustainable workforce? That has come up in the chat also from others. It has come from Snigdha. It came from Indra, that they don't have manpower. So how do you suggest that we have better forces? Do you find that we need to incentivize them? We are not able to retain people? We're not able to have skilled people first, then we are not able to retain them? Why is it so? Could you sort of in bullet points in the next 100 seconds or so, Suraj, say some of the points? How do you enhance the workforce and how do you make it passionate about the low vision areas in the region? Over to you.
Right, sir. Thank you so much. Before I answer that question, so as regarding the awareness, I just wanted to add 2 points. So when you talk about awareness, the first awareness among the eye care professionals and then awareness among the beneficiaries. So these two should have a different models. So at this time, we need to increase the awareness among the eye care professionals. So for that, we need to organize some kind of CME, seminar, symposium, this kind of webinar. It should be a top priority. At the same time, the awareness among the beneficiaries. So we need to have some kind of national level day, something like you have World Sight Day. That kind of mass level, so that the other beneficiaries, the general publics, they should be aware. Okay, this is the things happening. So we need to generate. We need to have this kind of device for our country. So this is just point I just wanted to add. Now coming to the Tanjali. So your question is skills enhancement. So here, in my opinion, I'd like to share 2 different approaches. One is a short-term solution, and second one is a long-term solutions. For short-term solutions, as you know, that being working in the government sector, so we need to collaborate with multiple sectors, like those NGOs, international agencies, organizations, CBO, and there's so many organizations who are willing to work in this area. So again, this agency, we do have a funding agency and agency who provide training. So for us, we need to collaborate with them, because in the government sector, there are so many medical colleges in India, and there are so many tertiary levels eye care hospitals. So very few provide this low vision service. So we need to collaborate with NGO, public partner.
15 more seconds for you, Suraj.
Yeah.
15 more seconds for you.
And the last
Quickly.
point is about incentive. So like, as you know, that for outcome-based incentive, we call it a facilitator incentive, because we know that eye surgeons, they got some incentive from the governments. So similarly, if anyone's disabled in the community, so that community, okay, one facilitator from the community able to issue a health facilitator to issue a certificate, able to enroll in the school admission, able to enroll in the vocational training. So that kind of output indicator we can design, and then there should be some kind of incentive from the government, from the relevant government. So that should be a good models. Like,
thank you. I fully realize, Dr. Suraj, and I see Dr. Sarah also wants to come up, and everyone here, that this is too brief a time. But the idea is to touch upon things. As I said, this doesn't close the topic. It's actually going to start the topic. And Dr. Tara Prasad is back on video. That how do we work together?
We could quietly enjoying.
Yeah, I know. And excellent conversation. So we need to possibly have a meeting. You have a meeting on LV itself. My last question is to Dr. Deepak Bagga before I take up, and I've requested the organizers for a few more minutes if possible. But the question is to Dr. Bagga. As I said, 6, 7, 8 are the strategic questions. So there, and Dr. Bagga, can tertiary level low vision rehabilitation services be financially sustainable? We find that not many hospitals, tertiary level hospitals, are ready to spend or if I can use the word invest in these. What's the reason and how do you go about? What do you have to say, Dr. Deepak, on this in the next 100 seconds?
Thank you, Dr. Nair. So a very useful question, and I'll bring 3 important points which can make it sustainable. One is optimum utilization of resources. That means adequate referrals. So having a strong referral mechanism can bring sustainability. Second is the pricing. So the way you price it so that you can recover from the customer itself. So at times, if you think that there are people who may not be able to afford it, so having a cross-subsidy model, like at LVP, we have a cross-subsidy model. So something similar can be adopted. Or if you are looking at the think of the charges which is not deterrent for people to avail the services. You want more and more people to avail the services and optimum utilization of services. And third point is, how can we bring the cost lower when we are buying assistive devices, so buying in bulk, but not having inventory that will not last for a year or so, maybe pooling together and can think of. So these are the 3 things which can bring the sustainability. And then
go ahead. Sorry.
Yeah, so maybe if we are not able to make optimum utilization, then the centers which are not sending referral in-house should be asked to provide the support to us.
Thank you. Very, very well said. Bullet points. Excellent, Dr. Deepak. But also the additional point comes up is investment by the institution itself, and that comes to advocacy and awareness. The point Dr. Snigdha and others brought about, Suraj brought about, that we need to have awareness and advocacy in-house. Even in WHO, we required it, to start it. And now it has come up because of the 80 has moved, low vision has come up. So that's one of the points. I'm going to quickly move to some of the questions. I know Asila has raised his hand and Sarah had raised earlier, and you also know, but I want to bring in some very good questions from the our participants. Sumit Grover talked about, and that anyone can answer quickly. Sumit Grover asks, importance of orientation and mobility training along with the LVA. Daniel asked whether ICAM model can be used, and Padmaja's questions has been possibly managed and answered. And Failin Soji asked core code from RWA, that's fine. So these are the 2 questions I would want you to. Asila, can you allow Sarah to come in first? Because she has raised her hand, then you next. To these 2 questions and come up with area. Dr. Sarah, over to you for your point, and also if you want to take up one of these very good questions.
Regarding the manpower for low vision, we can do a lot of training, but unless the person who's trained gets dedicated time, you will find that low vision services do not happen. If it's an optometrist who has to do everything else in the clinic as well, at least a session in a week should be reserved for low vision, otherwise low vision services take a back seat. And yeah, that's what I wanted to say about the training on low vision.
Thank you so much, Dr. Sarah. Over to you, Dr. Asila, for your point you want to make up, and I would want you to take up one of these two questions which have come up. Go ahead.
Yeah, thank you, sir. And we have Dr. Saman Senanayake with us, who pioneered to establish the low vision service in Sri Lanka. So just to take his point forward, and I think it's common to most of the countries in this part of the world. Sometimes you have all the facilities, we have the manpower, you have the necessary infrastructure, but at the end of the day, you don't have necessary low vision devices to provide to the clients. And on the other hand, sometimes we experience the clinics are busy and the priorities are different, and the clients are not identified as important low vision clients and referred. Yeah.
Asila, good points. I'd just like to come in here. Dr. Yodha ji has given us 5 more minutes. I don't want those also to expire. So talk about what you brought about the devices. Exactly knowing this, what we are doing now, WHO, we are procuring equipment of quite a high magnitude and sending to all the countries of the member states, exactly for this, what we call it as a live display, so people can see that. Secondly, for 80 labs, we call it 80 skills lab, that hub and spoke model like LVPI will build up with other places, CMC, Vellore will build up here. And thirdly, what we are doing is the twinning. And the 2 of the twins are present here, Dr. Surat Sanjam and Dr. Nahid Snigdha. RP Center is twinning NIO Dhaka to build the capacities, and we are sending equipment to NIO so that you could equip the lab better and they can start. So you're very right that we have identified, and although WHO does not believe in too much of procurement, but we had some money remaining at the end of this biennium, we're doing that. So to answer that question is that, as Snigdha brought about the WHO's advocacy, but we're also saying WHO is also coming into getting some equipment to places. So all the 10 countries will get some identified centers, will get some equipment, and there will also equipment for LVA. Of course, there will be on mobility, there will be intellectual, all disabilities. We are doing 80 for that. So wanted to bring to the notice of this area. Anybody like to talk about Daniel's questions? I comment. And Suraj, to you, because you have worked on it, on mobility training and orientation training. I remember that you have been doing with the blind school and others. In 30 seconds, can you say what Sumit Grover has asked?
Yeah, so that Dr. Sumit, he works in RP Center as well. So that orientation and mobility is such important, crucial for every one of us, irrespective of disabilities. So without proper outward movement, so we cannot participate the social events, employments, education, everything will be affected. So orientation mobility should be a top priority to me when we talk about the vision rehabilitation. Otherwise, someone is having a visual disability. He lives in a closed environments and without moving outside, so nobody will aware. Okay, this person is there. So the mobility outside is so important and very crucial.
So what you answer is that it is important you're doing it. I've been asked to wrap it up. I want to thank everyone, but I also want to bring up Dr. Sangeeta Abrol, as written from Lady Harding, that there is a people-centric model and research team in collaboration with the ICED, International Center for Excellence in Disability, that we can share and try to embed. Of course, Dr. Sangeeta, I in fact shared the today's webinar information today morning, and she and many of her colleagues have joined from Lady Harding. Many of the people who are there are because of Dr. Sangeeta Abrol's efforts that she wanted to sensitize many. Russell has been asking me that we can wrap it up with the last question. I'm not going to ask a question, but I'm going to give it to Dr. T.P. Das, who is the architect of this, and say any of the closing remarks. Of course, the thanks to everybody is there. Don't want to take time in thanking. We all know each other. We are all passionate group. We don't have to thank each other. And I apologize if I've not been able to take points from Beulah and Asila, but over to Dr. T.P. Das, sir. Please, with your viewpoints and close the session. I will not come back again so that we don't take extra time. Thank you. Over to you, Dr. T.P. Das.
I don't have any much comments to make that, but I am thankful to all the speakers and particularly WHO SEARO to coordinating this momentous work. And then I just reminding everybody that probably we'll have a meeting November 22 to 25 this year, partly virtual, partly hybrid, personal in Hyderabad, and we'll bring up these points again. Though cataract and refractive error as the UN resolution is will be highlight. So I will send a mail very quickly that if somebody can take voluntarily agree to summarize all that is being said, what is being all PPTs are available anyway under the care of Patanjali and or Buela. So that will be useful for our November meeting. And that will be document to be followed up and monitoring for next 8 years for the SDG 2030. Thank you everybody, and have a wonderful evening.